Hi, everyone. Thank you for joining us for the importance and impact of emotional intelligence in the healthcare professions. My name is Dr. Brian. I'm a faculty fellow at Barrett, the Honors College, and I'll be moderating this panel. We're joined by some really great panelists, and I'm going to give them the chance to introduce themselves, to tell us what they do and why, what particular expertise they bring to this topic. Dr. Piemonte, would you like to start the introduction?
Absolutely. So I'm Nicole Piemonte. I'm the Assistant Dean for Medical Education at Creighton School of Medicine here in Phoenix. I'm also a professor in the Department of Medical Humanities. My background is in medical humanities. I teach ethics and humanities to medical students. I also kind of support and teach residents, physicians, and medical students at St. Joseph's Hospital and at Creighton University. And my research and scholarship is around vulnerability in medicine and medical education, and what it means to develop the medical self and ideas of personal and professional identity formation in medical education.
Great, thank you. Dr. Fruzeshek Etka.
Yes.
Sorry, I'm going to work on it.
Hi, everyone. My name is Marjan Fruzeshek. I am an instructor here at the College of Health Solutions in the Medical Studies Bachelor of Science program. I've been here at ASU for probably the past 11 years. As an instructor, I've taught across multiple colleges here at the university. And now I'm here in the medical studies department. During that time, I was also in private practice as a chiropractor. I worked at an integrated clinic where we worked with medical doctors and chiropractors to co-manage patients. So I hope to bring a little bit of some of my experiences of what I've seen there to the panel today. And I'm also the degree director for the medical studies program here at the university at the College of Health Solutions. And regarding Barrett, I'm also a faculty advisor for that same program, for the medical studies program. I teach some of the well, I've taught many courses here, but the courses that are related to the discussion that we're going to have today is the healthcare ethics course, the applied medical healthcare ethics course that I'm sure some of our students have taken already. It's required across multiple programs. And another one is the leadership and professionalism program, which also touches upon emotional intelligence. So I'm looking forward to speaking with you all today, and I'm really excited to be here.
Great, thank you. And last but not least.
Yes. Hi, my name is Dr. Lisa Howdigi, and I am faculty professor in the Edson College of Nursing and Health Sciences. I'm a registered nurse. I have my PhD in nursing, and I currently teach professional attributes, which is a course, an intro course to our first semester nursing students, where we teach them essentially how to think like a nurse and to embrace characteristics that help in the nursing profession. Also, I've taught here at ASU for, this is like, I think my 5th year. And before that, I've taught at another university here in the Valley. My background is school health. I substitute as a high school nurse occasionally, and that's really my main background in nursing is inpatient pediatrics and then school health for the most part. So thanks everybody for having me join you.
Thank you. Thank you all so much for being here. And I just wanted to start by saying that the pandemic has changed so much about our lives, and some of us are at work and some of us are at home, and those of us who are at home might have disturbances of dogs or other things. So apologies in advance for the the messiness of life as the pandemic has blurred, exploded, challenged, made mockery of the work-life boundaries. And I also wanted to say that 2020 and the beginning of 2021 is a deeply stressful time, and I hope that everyone watching is taking care of themselves and their communities and one another as best they can as we stumble through these times together. So, with that, so again, thank you all for joining us. I'm going to start with a really broad question. The title of this panel is called The Importance and Impact of Emotional Intelligence. So how do you understand the term emotional intelligence as something that we can or ought to teach in medical school or to our undergrads who are hoping to move on to medical school? And I'll let whoever wants to start, go ahead.
I can start. So emotional intelligence, I guess, to me, I mean, we can look at healthcare providers as a whole and look at their experience, their education, the knowledge that they assess, which are all amazing and wonderful things to have as a healthcare provider. But it's that emotional intelligence that exists that really, I think, sets one healthcare provider apart from another and provides that quality patient care and that sort of bedside manner, which is what we kind of hear when patients describe how a physician or a healthcare provider reacts or responds in the room during an interaction. So that self-awareness of being able to kind of understand and be mindful of the moment and what's happening, of yourself, of course, and that patient that's in the room with you. Self-regulation, where you are able to manage your emotions and be calm and collected, being motivated to do your best and always looking to strive to improve. I think that's also part of it. And then just having empathy. That's a really big one. We always talk about empathy, and in healthcare, that is so important. And some of us naturally are just more empathetic than others. But for some, some of this can be a learned trait where we can go through and practice each of these components. So that's kind of what it means to me in terms of healthcare and the patient-doctor relationship and practice. But it could also be in terms of teamwork and management and all of these other things.
Thank you.
So I would echo so much of that. I think that when I consider emotional intelligence, really what patients remember, regardless of who the practitioner is who's caring for them, is how they made them feel. Did they feel cared for and seen and heard? And so often, I think that at least in medical education, the training is focused on some of the technical aspects of taking care of the biological body. And when my students at least start their third year, their clinical year, and start seeing patients, especially now, there's so much suffering in the hospital that's right next door to me right now. It really, what matters so much is addressing that suffering and responding to it. And I think historically, we've not done a great job of preparing our students to confront what I would say is the human condition, just suffering that's in front of them. And so when the question that Dr. Bryant asked about how can we educate for emotional intelligence, for us, that's looked like in our medical school, getting students to reflect on these bigger questions of what it means to be, what it means to suffer, what it means to die and be mortal. And that our students can't be present for patients in that situation unless they've reflected on that themselves and made meaning of that. So we spend a lot of time in our curriculum having students reflect on those hard questions that don't on their face feel like they're part of medicine, but are core to medicine, and getting them to write and think and reflect and engage in the medical humanities because they show up third year and go, wow, this is so much more than just looking at the biological body and giving lab results. So I think healthcare training across the country really does need to take a look at that and say, are we preparing our students for the emotional and philosophical elements that are there no matter what?
Yes, I really enjoyed hearing the similarities that we have in reaching our students. Something that came to my mind with emotional intelligence, and I echo this back to my students, and it's part of empathy. And Brene Brown, I don't know if any of you are familiar with Brene Brown. She does a lot of work around vulnerability and empathy. And I really try to hone into the students and to tell them that something simple. Emotional intelligence is just recognizing emotion in another person and communicating it back to them. So I really try to get our first semester nursing students to recognize emotion in their patients, and then to communicate that emotion back with peace and with composure. And I always tell the students, before you do that, you have to do that to yourself. So you have to practice. We're all come to the classroom at different levels of this. I have students who are able to recognize emotion within themselves first. It always has to. You give what you got. So anything I teach my students related to emotional intelligence and caring, they have to try and do it to themselves first. And so they come to the classroom at various different levels. It's okay. We can all be very good practitioners no matter what level you're at. And then as you go through your practice as a nurse, a physician, whatever healthcare track you take, you're going to have life experiences that are going to let you hone in on your emotional intelligence. But those are the keys: recognizing emotion in another person and communicating it back to them. Two other parts that echo some of Brene Brown's work that I try to incorporate into class as a foundation. She's a social worker, but it's relevant to all professions, is to accept another person's reality as their truth. And again, honing in on ourselves and respecting that what is going on in your world is true, and it takes recognizing it and then non-judging. So not judge yourself or judging other people. So that's kind of, and it hones into empathy. Those are four components to empathy. So emotional intelligence and empathy, just like Dr. Marjan Farjika mentioned, empathy is a very big part of it. So.
Thank you. I just wanted to say to our attendees that there's a Q&A function, and there's, I don't actually know if you have access to the chat, but anyway, please leave your questions in the Q&A. We'll have a short discussion. We'll answer some questions along the way, discuss again, and then maybe and hopefully go back to Q&A. So even though we can't see you, we want to try and make this interactive as possible. So just a little reminder to please use the Q&A. Okay, so you're all in the classroom. Some of you have private practice experience, but you're in the classroom. You're teaching. You're working with pre-med students. You're working with nursing students. You're working with student MD, future MDs. What are some of the challenges between like teaching ethics and emotional intelligence, like the theory of it, teaching it in the classroom, between and practice, right? That connection between theory and praxis. What are some of the challenges, and what are some of the promises or potentials that you encounter in the classroom? Dr. Am I saying that Harige? Am I saying that right? Would you like to start?
Sure. So in the classroom, I think what I enjoy doing, and it really can be a challenge sometimes depending on the mix of students, is I like to activate prior knowledge. So I like to, no matter what level of student comes into my classroom, you can be fresh out of high school, going into college, or you can be in my classroom as a second degree student. I've had people in my classroom who've been retired from the profession, so in their 50s and 60s. No matter what it is, I like to activate prior knowledge. What were some life experiences you have had that bring an ethical dilemma or a challenge with emotional intelligence? And let's talk about them. Let's break it apart. So that to me can be something promising to do in class, but it can also be a challenge because there are some people who come to the classroom with limited experience. And so I do find that that's a challenge. So anytime there's theory or a model that I want to show, I try to tie it in with something that has happened in your life where we can break it apart and apply the theory. In hindsight, it's already occurred. So that is something that can be a challenge when I have students in the classroom who may not recognize those experiences or may be shy in opening up because we all develop at a different stage. So that could be a challenge to I don't know if it's fear or just a personality of being more quiet and introvert. That's okay, but that could be a challenge to a good classroom discussion. I tell students, when you guys are in a classroom, you have so much to offer to your teacher and to others. We're all learning together. And something that's really good, I love it when my students will bring this up, is retail experience. So if they have come to the classroom or college with retail experience working at any place that sells things and has customers, there is a lot of opportunity to practice emotional intelligence or to recognize situations where, wow, this happened, I wasn't kind or I was a little bit snappy, but let's break it apart and let's look at these theories and how next time we might be able to handle it different. Then that's a win-win for everybody when we can take a past situation and grow and learn.
Lisa, I like how you are encouraging your students to draw on their personal experiences. I think that the temptation, especially in medical school, is to kind of divide my personal self versus my professional self, and that I can't bring my emotions or my experience, my sadness, my grief into the clinical setting. And I try to encourage my students that they absolutely can, and that vulnerability is what's going to connect them to the patient in front of them. To answer Dr. Bryan's question, the challenges of teaching these things in a classroom versus the real world clinical setting, it becomes painfully obvious in medical school, in part because the first 2 years in traditional medical education are in the classroom, and then the second 2 years are seeing patients. And so one of the challenges I have when we're discussing these kinds of topics like suffering and the lived experience of illness and death and dying is that it feels theoretical. And then my students aren't really seeing patients all that often to draw on those experiences. So it just remains in that theoretical realm. And the other huge issue is that in those first 2 years, what is most important? Well, what's most important ends up being my grade on my midterm exam and my final, or on my board exams. And when all of this fluffy stuff, which I think matters the most, isn't on those multiple choice exams, it's seen as extraneous and not important. So we're constantly fighting against that. The other thing is working against the hidden curriculum. So the hidden curriculum is that kind of invisible way of learning of how to be, right? So the visible curriculum during year 1 and 2 is be compassionate, be altruistic, be empathic. And then they go into 3rd year and they learn implicitly from residents and doctors, oh, this is how you actually are supposed to be. We don't have time for patience. We don't want to respond to emotion. And working against that hidden curriculum that conflicts with all those really great virtues that the students want to have is so hard, because that means changing mentorship and the interpersonal experiences that the students are having. And there are great, amazing mentors I just want more of them, because learning from those that are problematic really affects medical students, because they're being evaluated by these people. So they want to model that behavior so they get a good evaluation. But what if they're modeling behavior that runs counter to what we hope we taught them in years 1 and 2?
Yes, I concur with both my colleagues today. And, you know, it is a challenge. It definitely is. It's something that, you know, it's when we talk about empathy and self-awareness, all of that, and motivation, these are all things that are kind of feelings that, you know, have to be learned in some cases if we're not a certain personality that's very empathetic, for example. What I like to do in my classes, and the way that I think helps, is to present case studies to students of experiences that I've had in practice and situations that I've been in hopes that through the case study, they can kind of follow the process and kind of see what happens and how this interaction occurs with the healthcare provider and the patient. And, you know, there are many examples, but one of the, I think, most powerful examples that I've used in terms of case studies of things that I've experienced in practice is delivering bad news to patients. And that's something that's very difficult to do. And it's not only difficult for the healthcare provider, but I think for students as well, or any individual who's been in a circumstance where, you know, now you have to deliver news of someone's death or something terrible to someone else. It becomes a very difficult situation overall. So to be able to walk through that process and to kind of mentally imagine how that patient is going to feel. And the case study that I use in my classes, I'll share with you all today. It is a true case of a patient that was visiting our practice who was complaining of really bad back and neck pain. And it turned out that, you know, some blood work was ordered because this was an integrated practice. So they were also seen by the medical doctor, and the patient had anemia as well as high calcium levels. And then I was co-managing in hopes that chiropractic adjustments would help with the low back pain. But the patient was really in severe pain to the point that they needed medications to manage the pain. So before any type of adjustment was done, we did some x-rays. And when the x-ray report came back, very clearly you could see that there were punched out lesions, which you know, is a classic example on a radiograph of multiple myeloma. And this was a young woman who was in her 30s. She was a mother and she had children. So this is a very difficult case. And, you know, this is not news that we deliver over the phone. So the patient was asked to come in, and she was just basically told that there was some abnormal, you know, tests results that came back that we wanted to discuss with her. So she kind of had a little bit of an understanding of what was going on. But you know, to go through that process of meeting with the patient in the room, making sure that there's no distractions, taking the time to sit down on their level, make eye contact, give the bad news, pause, allow for the patient to be able to, you know, basically gather their thoughts. And sometimes when you give bad news like that, it's just, they kind of just only hear that and then nothing else makes sense. So it's always a great idea to have someone else in the room with them. And then just to be able to be empathetic towards how you would feel if you were in that situation. And to, you know, it's hard in practice, like you all mentioned, that it's difficult to put a lot of time. And, you know, basically it is a business where you're trying to see one patient after another and you have overhead costs and things like that. But to actually have that human component where you are now on the level of your patient and you know, you're being empathetic and understanding of what it is that they're going through, while also being able to control your own emotions. You know, I'm a mother myself, so this was a very difficult thing for me to see, and she was about my age as well. So it was just very hard, and to understand that, okay, I'm the healthcare provider, I'm the professional here, so I need to, you know, maintain my composure. But to go through that, and, you know, it becomes very powerful to show a case study like that to students in the classroom and kind of walk them through what this process looks like when you're actually in practice rather than just reading about it, and kind of asking them, how would you react in this situation if you were the patient or if you were the healthcare provider, and just kind of do some role playing together in the classroom in small groups to see what works and what doesn't in these types of situations. And sometimes talking it out is really the best way to move forward. So that's kind of some of the things that I do in the classroom with my students, is to try to bring some experience into what really happens and what I've seen in practice into the classroom. So yeah.
Excellent. Well,
One last comment is that we can put our students in a clinical setting, any type of students, but they may not encounter an ethical issue or something that lets them practice emotional regulation, right? So simulation and case studies are excellent. I use cinema, movies are another excellent way to bring those experiences to the students if they cannot get them out in the practice setting.
100%. Yeah. The use of any audio visual or anything you can bring into the classroom where, it makes that impact to where you see, wow, it's different from reading it through in a textbook for sure.
Yeah, well, you've kind of answered the question from one of our attendees that says, how can pre-health students practice building emotional intelligence now? And so if anyone in particular, Dr. Piemonte, if you mentioned medical humanities, if you could explain to the audience like what that is, how might literature and other and the humanities help us in this space?
Yeah, absolutely. Thank you for asking that question. So the medical humanities are a little bit like they sound. So drawing on the humanities, literature, history, anthropology, cultural studies, philosophy, to think about the practice of medicine. And so there is a push to have pre-health humanities for our pre-health students, because there are classes that are not on the hard sciences, but are related to health and healthcare that can help articulate the lived experience of illness. What might it be like to be a young mother who gets diagnosed with cancer in a chiropractic office when they never expected it, right? And data sometimes can't speak to that. Statistics can't speak to that, but literature and film and music and poetry can speak to that, and being really reflective. So I would say to Danae's question about what can a pre-health student do, I would say expand your repertoire of classes that you take before the health professions, because a lot of the health professions schools now do have ethics or humanities. And it's a shame to introduce students to that at that point where it's too late and they start saying, I wish I would have done more of this in my pre-med or pre-health training. I know that Creighton, for example, wants applicants who've had exposure and engagement with the humanities, because we know that the questions a humanities course asks are very aligned with what you're going to see when you're taking care of patients, no matter what health professions field you go into. I would say reflecting on how you feel, how you respond to others, and then volunteer experiences. Maybe you volunteer for hospice or in a clinic, and really being around patients. I mean, sometimes it's scary to be around sick people. You're afraid you're going to say something wrong. Someone has a terrible diagnosis or who's dying, and we're afraid we're going to make it worse. And so just like that exposure and watching mentors do that work can really help you build that emotional intelligence now. And I would say even at least reflecting or writing about it when you get home, what that experience was like, and what it felt like to be there, and what you wish you would have done differently, or what you're glad you did in that situation. There are lots of experiences you can do now to kind of take some of that fear away so that you feel more equipped when you're in your health professions training.
And here at ASU, we also have a couple of our courses. We have leadership and professionalism, which again is required across multiple programs. And there is a whole chapter in that course that deals with emotional intelligence. Our healthcare ethics course also has emotional intelligence as part of an important topic that's discussed in many different sections and ethical theories, as well as a humanities course we have in healthcare that is also, again, across multiple programs. So at some point or another, at the College of Health Solutions at least, there will be some courses where there will be discussion on some aspects of emotional intelligence, or specific chapters dedicated to emotional intelligence. So you will have, as a health student at ASU, at the College of Health Solutions, you'll have some exposure to learning more in detail about these processes that we've discussed as well.
Yes, very good. Excellent, because ASU and other universities do set their students up very nicely a lot of the times with prerequisites. Things you can do daily, in your home to build up that emotional intelligence is mindfulness. So if you can practice quieting your mind, it's like a muscle, right? You have to work with it daily. It might be hard in the beginning, but mindfulness can help you identify and label thoughts and feelings you're having. And so I think that that's a really good step that you can do every day, is label thoughts and feelings, and to understand that feelings are not right or wrong. Feelings are just there. They're there to tell us something, that, you know, if I'm feeling angry, what's going on within me? If I have fear, what's this feeling telling me? So if you could practice that, identifying feelings, I'm angry, and maybe that's where you're at. Or you can maybe investigate a little bit. What is this feeling trying to tell me about myself and about this situation? So that to me is everyday steps. Of course, the universities have set you up nicely, but those are some good steps to emotional intelligence. Embracing those feelings, even if they're difficult to have, and journaling. I think Dr. Piemonte talked about reflection and journaling. That's a really good activity to do. Practice gratitude, things that you're grateful for, and that'll help you go throughout your day and recognize things that are positive and things that could be uncomfortable. So those were a couple things that I thought about while I was hearing my colleagues. Excellent, lots of great ideas.
I wanted to think about for a minute how the pandemic has shifted these conversations in the clinic and in the classroom. So we know that COVID has changed how we think about time, right? That we think in terms of days of quarantine or time of incubation, or time to vaccine, time between vaccines. We think about scale, right? We're currently, I think we're over 5,000 cases a day just in Arizona, and over 3,000 deaths per day across the US. It's raised a lot of fear. It changes conversations about fear. It changes conversations about risk, right? It seems like at times we're all left to kind of manage risk on our own. What does that mean for us? What does it mean for our families? There's a lot of uncertainty and a lot of isolation. So I was thinking, is there something about, well, I'm sure there are many things, but what has COVID revealed to you and your students or the residents that will be a key part of your ethics and medical humanities and emotional intelligence conversations moving forward? It's a big question, but I think a lot about how COVID has just changed my pedagogy in my human event class. And Dr. Piemonte mentioned earlier that the suffering, like, it's there, it's palpable. And so I was just wondering if you'd reflected on your own or with your students about what this means or what it reveals for us in a way that wasn't so obvious before.
I can speak to that. So there are a lot of things that have changed. So at St. Joe's, we started Schwartz Rounds, which is this opportunity for healthcare workers to share their stories. There's always a lot of focus on patient stories, and rightfully so, but an opportunity to share their stories. And since COVID, obviously, those stories have been really painful. Our healthcare professionals in the hospital have PTSD. They're overwhelmed. There's a lot of trauma. And then their colleagues who might not be on the front lines have this kind of like vicarious trauma where they're so brokenhearted over watching their own colleagues being traumatized, right? So creating spaces to articulate that, to express vulnerability, to feel solidarity that you're not the only one suffering. Like these are immediate needs that we have in the clinical setting. And that has changed a lot because talking about vulnerability is not really something medicine does well. But I think COVID has forced us to acknowledge that because our colleagues are very unwell because of the amount of suffering and mortality that's around them. When it comes to my students who aren't yet in the clinical setting, who some of them have guilt for not being able to be in the clinical setting and to help, some other things that have changed is really the ethics of what we're asking healthcare professionals to do. So we've looked historically at physicians' responses to pandemics globally, right? The bubonic plague. There's been all sorts of pandemics that we've had over the history of the world. And oftentimes we see physicians flee during that time. And the ethical question of when does a physician get to say, no, this is too high risk for me, for my own family. I didn't sign up for this. And what we've kind of concluded with my students, at least, is I do want to be there. I feel called to be there. But I also feel like there's a societal duty to protect me while I am there. We should have had enough PPE. We should have had a safe way to provide this kind of care. We shouldn't have this medical model that's so broken and precarious that any amount of overwhelming it and it crumbles and we can't take care of people. And so, yes, they've got an altruistic call to care for patients no matter what, but that doesn't mean society can ask physicians and nurses and techs to do this work without also holding up their end of the deal, which is we're going to have a responsible government that makes this safe for you to provide that kind of care. So this is an issue we've always had. What is society's obligation to take care of patients and practitioners alike? But it's so obvious in this pandemic that we're able to talk about it in a new way, for better or worse.
Yeah, I mean, we have completely changed our ways of learning in the classroom, of course, with the whole COVID situation and how we administer the courses and how the course delivery, all of that. And then, of course, in the classroom, the concern, the students sitting 6 feet apart, there's a lot of, I want to say anxiety might be an okay word to use here. It might be too strong, but there's a lot of worry right now overall with this whole situation. And if we look at, the ethical dilemmas and theories that can be applied to all of this, I mean, there's so many that can be discussed. It's funny because on Tuesday in my healthcare ethics class, I have a fictitious case that I go through with my students on the first day of class where it's called the 50 pills problem, where there is only 50 pills and you have 100 patients, and then this physician has to determine how are we going to distribute the pills and save the most lives. Some patients need 1 pill, some patients need 2 pills. So it's just kind of a start to kind of get the students into thinking not everything's not black and white in ethics. There is a gray area where we have to kind of think about using some of these theories and how to move forward as healthcare providers. And it's interesting because we were having that discussion and I told the students, I said 2 or 3 years ago, I would say that this case is something that you probably will never have to deal with and you'll never have to worry. But now with vaccines, we're in that situation where there's not enough vaccines yet for the entire population. We're moving through in phases. Certain states are taking, different age groups, and certain states are providing healthcare providers first, and then the most vulnerable populations, and then so forth. So we are now in this same situation that we've been kind of discussing previously as something that probably would never happen. And it's just very difficult to wrap my head around that, in Los Angeles County, for example, the paramedics are being told if patients don't have a high chance of survival, not to bring them into the hospitals because they're overcrowded. I mean, these things are things that I would have never imagined. And to be able to discuss this now in the classroom with the students as real life events and current events that are happening now, and looking at those ethical implications, and not, using these cases as something that probably wouldn't happen, but I just want you guys to start thinking about it. So it's definitely changed the way that we think, the way that we learn. I think there is a great sense of respect now, more so than before, for our frontline workers and healthcare providers, and even our essential workers that are in the field right now, working hard and putting their lives at risk with the limited PPE and things that we've seen over the past few months and even this past year. So definitely there's been changes, and it's just amazing to see all of this happening and unfolding the way it is now, and going through it with the students together.
Yes. And, to think as a faculty, I have to think of my students as having maybe possibility problems of their own. Are they able to afford their bills? Are there children? Do they have children? Are they in school or are they home? Do the parents have to step up and help their children with online learning? So COVID has made me as a faculty have more empathy. Maybe I should say I'm always working on that skill, but giving them some more leeway, listening to them. I remember I was teaching a class, and it was at the end of last semester, and this is when the pandemic or things were being closed down for the first time, and it was so hot in Arizona, and students were actually voicing concern. I've had to turn my electricity bill on so much earlier, and I'm going to have this higher bill now, along with, along with not being able to go to work and my kids being home. So COVID has really made me look at my students more holistically. Usually I try to do that, but it has really forced me to look at how politics are impacting them, how the school system is impacting them, various things. Another thing I want to think about, and I'm glad that Dr. Piemonte brought this up, our frontline workers with PTSD. We have to think of the future, and it'll be really, we're going to be jumping into emotional intelligence, because we may possibly see violence increase, substance abuse increase, possibly people are losing homes, because if they have these feelings that they're unable to work through, it could be the person at the grocery store, it could be your physician, it could be your nurse. There needs to be a way to take care of them and to vent and to debrief these experiences and feelings. So I think that as a faculty, it's really helped me hone in my skill on looking at a person holistically and practicing my emotional intelligence more so.
Yeah, that's an excellent point. I'm the coach of ASU's Ethics Bowl team, which is about, it's kind of a debate competition where you can get points for agreeing with the other side. But one of our cases was about, do doctors have the right to stop working in a pandemic, right? To refuse to say this is too much, which really brings into focus the quote that Alondra Nelson wrote when she was writing about the Black Panther Party's network of free healthcare clinics in the 1960s and 70s, that healthcare is politics by another name. And I think one of the things that COVID has done is to bring it shows that medicine, that bioethics is a deeply political undertaking in some ways, right? But I wanted to, thinking about, so we've all talked about nurturing empathy, and when one of you mentioned, the respect that we have for frontline workers, but I'm wondering, the narrative around wearing a mask right now is that it takes care of other people, right? That my mask protects you, your mask protects me, which is fundamentally a call for us to be empathetic, to care for one another. And in many ways, it's been a struggle, right? So what do you make of that? We could just reduce it to partisan politics, but on the other hand, it reveals the ways in which there is a lack of empathy in lots of ways, and it challenges this idea that we do actually have a lot of respect for frontline workers who are overwhelmed and have PTSD. So I guess as you and your students watch the larger rhetoric around, like, how do we protect one another in a pandemic, what does that tell us about empathy and whether we have it or how to cultivate it for others? Does the mask discourse, I guess to reduce my question, does the mask discourse reveal something new or something missing about empathy in society writ large?
Well, I just have a couple things I'd like to say, short things, because this is an opportunity for me to continue to practice emotional intelligence. When I see people not wearing masks, I have to take a deep breath and try not to pass judgment. It's very difficult. Is there a knowledge deficit within that other person? Do they not fully understand the science behind it, or the reason or the rationale? I think about that. Also, I think of a person's developmental stage, because working with teenagers, they're 10 feet tall and bulletproof, right? They have that Superman mentality of, it can't happen to me, it can't happen to my family. And so it is a very difficult thing to see and to understand. And I try very hard to withhold judgment related to this, but I just think of various different things: a knowledge deficit, possibly their developmental stage, their mindset. It helps my anger or any feelings I may have kind of be a little bit less. Just model, continue to wear my mask above my nose appropriately, not under my nose, and just continue to model to smile, to be kind, and to hope that people may change and learn. But there's a couple things that came to my mind.
Mm-hmm. Spoken like a true nurse, who you are at your core. I love that. And I love the idea of potentially thinking that maybe this person is at a developmental age that they don't look like on the surface. I think that's really, really helpful. Something that I will try to do as well. So I think that what this has revealed is the slipperiness and the difficulty of empathy and what we mean by empathy. So I think it's hard for people to empathize with like the ambiguous other, this like amorphous stranger or a theoretical stranger. Like, it's hard to empathize with like other people who need me to wear my mask. It seems to me that once they get sick or their loved one gets sick and they see that suffering firsthand, then maybe they get it. I want to believe that some people are naturally empathic and have this empathy for this invisible other that we're talking about. But my experience has shown me that some people don't recognize that empathy until it's up close and in their face and personal. Mm-hmm. And this is why when I think about cultivating empathy, it's not going to come with these kind of like grandiose calls to be empathetic or a pledge for compassion or whatever it is that we do. It's going to come through either personal experience or a compelling story that just like grips you right? And that's why the humanities to me are so important, because when I can understand the suffering of another person through a narrative, through hearing about how they suffered or died because someone didn't wear a mask, that's more compelling for me to have empathy than to say, hey, you ought to wear your mask because it's the right thing to do. Those vague statements might not be compelling to people. They have to feel it and experience it.
Yeah, absolutely. I agree. And, you know, I couldn't help but wonder or think for a second, Dr. Bryan, when you asked and you mentioned, you know, my mask protects you, your mask protects me, we're doing this for each other. I mean, could this whole COVID situation and, you know, wearing the mask and some people being so resilient to it, could that be a measure of the actual emotional intelligence level of our society as a whole? You know, as we're going through this process, and could this be the ultimate test to see kind of where we stand? And could we learn from this process? We talk about emotional intelligence being a learned process, and you know, empathy being a large part of that, but just looking at it as kind of a larger umbrella term. Could this be kind of the be all of what's to come, and how difficult it really is to learn what emotional intelligence is and to apply it in a real world setting when you have a situation like this? So that just got me thinking. That was a really good question that you asked.
Yeah, I mean, I was thinking, if we think very specifically about what a good ethics class or a good professional leadership class teaches, right, that we're thinking about building specifically our capacities for self-criticism, which is not something, which is either something we either engage in way too much or not nearly enough. Moral imagination, right, where we're thinking kind of big, where this ties to what Dr. Huge was saying about really being in touch with kind of your initial emotional response, and then to use that time for reflection, right, and for sharing with other people, like when you were in this space, what did you do, what could you have done, right, exercising that kind of moral creativity muscle that we don't, or imagination, right, where we're thinking big about how we could impact the world, how our actions do impact others. And John Dewey wrote back in the 30s that part of this was about cultivating a wide awake, careful, thorough habits of thinking, right, which are, like, as Dr. Piemonte said, like, can be seen as fluffy and yet are everything, right? They are kind of what this all comes down to. I have so many questions. So speaking of, okay, so we have all of these cases. Bioethics has exploded in the last 40 years. Just yesterday, a doctor tweeted, like this tweet if you are a woman and you have ever been ignored, gaslit, accused of exaggerating, or told it's all in your head by a doctor when you sought help for a medical problem. And there are almost 30,000 likes just in less than a day. And so, of course, my question, I'm going to make it really broad. So my question is, and you can take it wherever you want, but we can't divorce the conversation of emotional intelligence or ethics from larger systemic issues like sexism, like racism, like classism, or even capitalism. And so how, and maybe this ties back to the question that an attendee asked earlier, but how do we teach about things like anti-racism in a bioethics or medical humanities class, or how do we get pre-med and med students and nursing students to say, you know what, these larger societal structures are really important, even if you're only intervening in the clinical setting one-on-one, but what's the role? Sorry, this is a meandering question, but what's the role of, let's say, for example, anti-racist education or feminist education in pre-med and med education?
Okay, this is a really good question and one I've been thinking about a lot because we've incorporated, so we've got a group of medical students at our school, so the White Coats for Black Lives, and we've been getting to work with them, which has been really fun, and incorporated a lot of anti-racism as part of our humanities and ethics curriculum. We've got a book club among the faculty at Creighton, reading how to be an anti-racist and having those conversations. And remember that Creighton's main campus, it's a Jesuit Catholic medical school in Omaha, Nebraska, right? So these conversations can be a little bit difficult, but so important. So we've been incorporating it into medical education, and it requires so much emotional intelligence among our faculty and among our students, because these conversations are hard and painful, and they're hard and painful for different reasons and different ways, because they're pushing against some people's like narratives of their whole life and their family, and it feels threatening and they feel attacked. And so how do you authentically listen to your classmate when they fundamentally disagree with you, and then fostering those conversations? So what our students are doing, and maybe not realizing it, is learning to have those kinds of conversations in a safe way where people are heard, which is so hard, is actually preparing them to take care of patients who are so different from them and have different thoughts and beliefs and understanding of what's going on with them. So the part of healthcare education that we need to acknowledge is that it's a moral education. We are teaching people how to be, not just how to be a doctor or a nurse or an OT or a PT or a PA, but how to be in the world when confronted with really difficult, challenging human interactions. So I think as educators, we have to have those conversations that make us uncomfortable, that make everybody uncomfortable, and then model and teach how to listen to each other well. Empathy is huge here, because I know that there are students who are with us here today where having those conversations is so hard and get so tempted to be like, why does this person not get it? And then learning to listen to them and speak truth to power while listening to them and not dehumanizing them is a lifelong skill. And it needs to start now, and it will make you a better healthcare professional.
Absolutely.
They are difficult conversations to have, and we tend to move away from things that are difficult and kind of want to be in our comfort zone and have conversations that are comfortable. But I do think that certain conversations do need to happen, and in the classroom, at least, there needs to be a very inclusive environment, of course, where, especially in ethics courses, where there's discussions and things like that in small groups, students should be comfortable expressing themselves and understanding that we have different viewpoints, we have different backgrounds, we have different ways of thinking, and to be respectful and to be able to have empathy in terms of understanding where someone else is coming from, and putting yourself in that person's place. So again, a lot of the aspects or components of emotional intelligence can be applied here as well. So it's really is truly wonderful to see how we can apply emotional intelligence into the classroom when it comes to diversity in the classroom, and as well as, teamwork, working together, and small groups, all of that.
And I could just think of one word: role modeling. Role modeling, because making sure that our colleagues are able to have that safe space to verbalize how they feel without judgment from their coworkers, that is a really good start on they come to us, everybody comes to the classroom with different life experiences, and they can impact us, but they can also impact us in a positive way if, as faculty, we can role model and help foster emotional intelligence and listening to another person's point of view, walking in their shoes, so to say. And I think that that is an important thing. I've been a nurse for 30 years. And so I went to nursing school 30 years ago. Two things stand out from my nursing education, and they're not even about being a nurse. They're about being a better human being. I had two faculty. One taught me the concept of caring in the hospital. I just watched her. It sticks with me to this day, and I share the story quite often. Another one was a faculty member who called me into her office, and I thought I was in trouble, but instead she praised me for some actions I did as a mom. So she helped me be a better mother. So I really think that we do have to have that avenue for our students, but we also need to take care of our colleagues and ourselves for that safe space and role modeling. And finding a mentor, finding mentors who display those characteristics.
You know, when you talk about a safe space, which I think is so important, I mean, I think things that I'm still learning about is that creating a safe space doesn't mean we have to tolerate things that might be dangerous opinions that people might hold. So I'm continuing to learn how you compassionately respond to someone who might be saying something that is fundamentally racist. Like, to me, racism's not an opinion, and it's not like, oh, let's present both sides of this argument, because the other side of how to be an anti-racist is how to be a racist, and I'm just not teaching that in my classroom. So, but there is a way to compassionately and kindly not allow dangerous rhetoric. And I'm learning that, because I would often err on like, oh, let's create a safe space where kind of anything goes. But no, it should be, let's create a safe space where not everything goes, and we can challenge ideas in a way that a student doesn't feel attacked and then shut down and silenced, and then there's never a transformation that happens then. So I'm still learning these things.
Oh, it's a tough one. And I remember listening to one of Maya Angelou's, I forget, interview. She was interviewed, or I forget where I heard it. But somebody was in her home and told a joke, and she just kindly got up and said, "Can you please exit my home?" So I hear you. There's a fine line where we develop, and she just explained, I don't want that on my walls. I don't want that type of rhetoric in my home. And so I'm sure it takes, as faculty, a lot of error, a lot of, ooh, I could have done that differently, or next time I'm going to do this. So we have to reflect and journal and do some self inspection to fine tune those skills of making it a safe place for everybody. Yeah, it's difficult.
Definitely a learning process, and just being motivated to improve and to learn every day is also another component of emotional intelligence we can bring up here, is motivation and being motivated to learn and to self-improve.
Yeah, I mean, I think that's all. Yeah, I think that those are really important points. And also, and Dr. Piemonte said, that these conversations require emotional intelligence. So if you're looking to build your emotional intelligence now, join an anti-racist book club or something, because actually learning how to have these conversations about people who are different than you is really important training for the deeply interpersonal work of medicine, right? That in many ways, I think a lot about safe spaces too, and I'm not sure how to make them safe, right? When you don't know the people in the space, and when you're all still learning together, it requires, if not, perhaps not a promise of safety, but a commitment to vulnerability and care, right? That it's going to be uncomfortable and it's going to be painful, but at least like that can be shared and nurtured together. Because I was thinking about, I have a friend who teaches, so in almost every year I have a few thesis students who say, I want to study how medical schools teach LGBTQ health Like every year they want to do their thesis on this, and they're often shocked and appalled that the medical school curriculum for LGBTQ health is only, I mean, Dr. Piemonte would know this better than me, but like 5 hours, we'll say, in a squished curriculum. And then that 5 hours is dismissed by some students as, well, this is just, the takeaway is don't be a jerk, right? That people are different, just don't be a jerk about it. Like, and I guess, how do we, so I guess I want to go back to the medical school curriculum and the hidden curriculum, but how do we help students, pre-health students and nursing students and medical students see that this is much more complicated than just don't be a jerk?
Oh, how we can help them see that's much more complicated than don't be a jerk. I think it's because it involves so much of you. So for me, it's trying to get students to see that showing up and being a healer, no matter what that looks like, requires so much of you and how you feel and think, and reflecting on maybe you're uncomfortable if you're taking care of a patient who's transgender. Okay, that's fine, right? But acknowledging that and reflecting on that is huge. What we're trying to do in our curriculum is sometimes the temptation of just don't be a jerk curriculum gets smashed into like ethics and humanities, which can feel separate from my real curriculum of learning how to be a doctor. So what I'm trying to encourage is in their endocrinology course, in their reproductive course, let's teach medicine not on just heteronormative white cisgendered bodies, which is what we tend to do. So if we can start teaching medicine about diverse bodies that don't look like the typical body that's in a pathology textbook, we start learning that I'm called to care for everyone in every way, shape, and form, and not just this one kind of either normative or pathological body. So I think we need to infuse this way of teaching throughout the curriculum and not just in like standalone sessions that tell you like, oh, you're going to have some weird patients sometimes, and here's how to not be a jerk with them. But learning that all patients are so different, and that medicine is much more complicated than we want to think, because people are so much more complicated, and your responses to people and how they make you feel are so much more complicated, and life is just complicated and messy, and medicine's not just an applied science that's black and white. So let's get real comfortable with the gray. So that's more than LGBTQ plus community, sorry, but that's just like medicine is complicated. So buckle up.
I think planting seeds. So if as a student, if you can be open to taking in what your faculty share with you, a medical student, a nursing student, and just let the seed get in your head, just plant it, because life experiences, I think, are really going to be key. And just be open to taking various types of experiences and reflecting and becoming a better person after it. So it's continual. It's a critical thinking theory clinical judgment theory that we impart on our students, that any experience you have, there has to be a reflection that goes with it so you can learn and come out a different practitioner. So I think that is a big part of accepting and being that excellent provider for a variety of cultures, non-ethnic cultures too. I use culture being ethnic and non-ethnic, the culture of the LGBT community, what have you, is to don't expect to know it all right away, okay? And feelings are going to come up within you that may be uncomfortable. It may be from your life experience, your culture, how you were raised, whatever it is. But don't be afraid of it. Sit with your feelings, identify it, reflect, and grow from it. So be open to seeds being planted.
So for me, I guess, you know, I consider myself a minority female. I know we're talking about, I guess we kind of decided to get into a more general conversation about minority rather than just that one group that you were referring to. But I think my experiences and what I've seen and the idea of planting that seed, like Dr. Lisa mentioned, it really early on, understanding that and being able to cultivate that is something that really has helped me see the world differently based on my experiences and how I grew up, and kind of spread that out to those around me and students. And yeah.
Yeah, no, thank you. Just a reminder to the attendees, I would love to hear your questions. So please use the Q&A or the chat function so that we can make sure that we're moving this conversation in ways that are relevant to you, that address the concerns that you may have. Just as a recap to answer kind of some of the key things that undergrads can do, the panelists have talked about taking classes that that force you to engage with literature and the humanities, to engage with case studies, to journal and reflect on emotional experiences that have been difficult for you, and to think about the prejudices that you might have about what are the hard, quote unquote, important skills versus the soft, quote unquote, unimportant skills, and the ways in which those distinctions don't make any sense in our really messy and complicated world. One of my goals for my students is always that, I think Dr. Foruzeshetka mentioned earlier, that part of our struggle for those of us who teach bioethics is not just getting them to acknowledge that there is a gray area, that there aren't black and white answers, but actually that the gray area is the most important area. I mean, that's one of my lessons for my students, is that how do we talk about uncertainty and complexity in ways that are kind of more robust, right? So that we can learn from the ever-present grayness in ways that don't just make us feel like, oh, it's all relative, it doesn't really matter, right? Because it does matter. It just matters that we kind of find the moments of precision in that landscape. Okay. I have a question about care and cure, and there are lots of ways to take this, but what do you think? We often stereotypically think that care belongs to nurses, right? That kind of nurturing, caring interactions, that's the domain of nurses. And cure belongs to doctors, right? It belongs to those who've been in med school for 4 to 8 years, who have a different kind of expertise. So why do we think that endures, and what are some ways that we can push against that so that students don't go into these careers thinking that they're limited in these particular ways, that these are solely the domain of these particular professions?
Okay, I have lots of thoughts on that, but I will try not. I'll rein it in. Okay, so care versus cure. I was just reading something the other day from a physician who, when he had asked a group of pre-meds and said, what do you think the job of the physician is? And they said to fix and cure. And he said, well, if that's the case, then when you become a physician, you need to kind of unilaterally refuse to care for patients who are chronically or terminally ill. If your job is to fix and cure, then those refuse to care for them. Right. And that's very black and white and very extreme, but it kind of cuts to the core that there are so many patients for which cure and fix is not an option. they live long lives with a chronic illness, or they're dying. And turns out 100% of patients die. So if that's the idea of the healer in your mind is the fixer and the curer, then you might really want to reflect on whether or not you want to go into medicine. And so why does this kind of separation of cure and care just persist no matter what, or saying that this is the role of the nurse and this is the role of the physician? I think there's two reasons. I think one is our curriculum, our pre-med and medical curriculum perpetuate it. By focusing so much on biological intervention, technical skill, hard science, multiple choice answers with right and wrong answers. And I think because caring well for someone who you can't fix is hard and painful and vulnerable and makes you feel a particular way about yourself. And there's ideas about failure that endure in medicine, and that caring well for people as they approach the end of life requires humility and all sorts of pain and emotions. And as human beings, we'd rather turn away from that. And what an easy way to turn away from it when you say, oh, that's okay, my job's to look at these lab values and to take care of your body and give you these test results. That's really tempting to focus on that because all this other stuff is really hard and your medical school didn't train you how to deal with it. So it endures and endures, and then that hidden curriculum of showing up during third year and going, oh, we just focus on the body. Okay, that's right. Dr. Piemonte and her weird faculty were wrong. Like, this is what we're going to be doing, right? So things are changing. Things are changing in the curriculum. They really, really are. But that kind of culture change is slow and hard. It's going to take a long time. And also teaching my medical students the humility of how they can learn so much from their colleagues, especially their nursing colleagues who might be bringing more healing to their patients than some of the groups of doctors. So, and finding really good role models. My husband is a hospice and palliative care doc. He takes care of the dying people, the ones he can't fix and cure. So, you know, every single night we talk about these things. So I feel really passionate about it, but we need to do a better job of getting physicians and anyone in healthcare to see that cure and fixing is not the ultimate goal of medicine.
So if we can think, if we all, you know, sit here for just a second and reflect how good it felt when we were listened to, right? Or when we had somebody have empathy with us, right? I remember a while back, I was going through a difficult time. Somebody just came up and gave me a hug. And I'm like, whoa, did that feel good, right? So if we can think about those times in our life, no matter what background, no matter what degree we are obtaining, and to kind of reflect on that feeling of how it felt. And then I love the way Dr. Marjan said, cultivate it. How can we cultivate that in order to become more, have more of that come from us? So there's a quote I had a colleague shared, we would do home health simulation. That's where we would really connect with a lot of students. We'd have an apartment and she would tell our students during debriefing that your patients don't care what you know until they know that you care, right? Your patients don't care what you know until they know that you care. So once you've got that connection with your patients, then I think that healthcare goal setting towards health and healing, not curing, but healing, can take place.
Absolutely. You know, I agree. I remember when I was, when I had my C-section, I was in the hospital and I stayed for about 3 to 4 days, which is, I guess, standard, but I received so much love from the nurses. I mean, every shift, they were all amazing, wonderful, caring, the way they treated me and my newborn and my husband who was staying with me as well. It was just, I will never forget it. And, you know, with the physician, it was a little bit different because you have that limited interaction. And and that whole idea of, they're in and out quickly, but then, your nurse comes in, she talks to you, she stays in the room with you. It's a very different interaction. And, these preconceived notions start to come up in your head about how, the nurses are more caring, the physicians, the role is different. But, in our courses here, we try to teach patient-centered care, where there's a caring response in your relationship as the healthcare provider, as the physician with the patient. And that's so important. But again, when it translates into practice, it may not always be the case. But on the other hand, I had a friend who she has cancer, and it was a stage 4 type of muscular cancer where she was being treated at Mayo Clinic. And the situation there was completely different. I mean, those were physicians that were dealing with a patient who there was no cure. So there was no, let's fix it. It was obvious that she was in a condition where, there wasn't any turning around from it, but, through palliative care and, they were basically making her comfortable. And she received so much love and genuine concern and care and time from her physicians at Mayo Clinic as she went through that process, and the same for her family. So, I think it would depend on the situation and what's happening, because there isn't a cure for every condition. And then we have physicians like oncologists who are treating patients who are going through cancer, or hospice and palliative care, where it's kind of like end of life care, where there is no cure in sight, but you still have that caring response occurring at the same time. So, yeah, we're getting there, and things are hopefully improving in the way that the education is coming to our new doctors that are being going out into society and practicing. So there's definitely improvements with that. But again, it's kind of like this preconceived notion of how the nurses are caring, the physicians are just doing their job, they're in and out, and so forth.
And I'd also just point out that you said love twice. And I think that that's so important, because if we conflate emotional intelligence or professionalism with detachment, we're just really doing a disservice. I think there are physicians and nurses who will say that they showed love to a patient, or that there was that loving well is part of this, which is so strange to say, and it's really hard for some people to say in medicine, but caring for someone when they're at their most vulnerable is a loving act. And I think we just need to be more comfortable talking about that kind of human connection. Yeah, I mean, is there a balance? Do you have to be responsible for your emotions in a clinical space? Yeah, you do. You need to be mindful of those things, but to pretend that you don't feel pain, grief, and love in medicine, that's what leads to burnout, I think, because you're just kind of detached and numb.
This might be a follow-up from the previous question. It might be something different, but when is healthcare, and we can take that as the system or medicalization, or when is healthcare a source of suffering, or when is it most powerfully in your mind a source of suffering?
Too often, I would say. The fact that access to healthcare is not for everyone, I think, is a real source of suffering. I think feeling like a number or an anonymous patient who's dismissed or not seen or heard creates more suffering. And I also think that when there's just a myopic focus on treating your body and ignoring all of the existential emotional suffering that you experience, exacerbates suffering. It is worse to just focus on these interventions that might be bringing you more pain than treating you as a whole person. It's almost like you'd rather not get any kind of medical care. And we've all had we've had loved ones that we've seen who had a medicalized experience all the way until the end and didn't get to have that full human experience at the end. And I think that causes more suffering than if they just had avoided the hospital altogether.
I think it's a situation, and I think Dr. Permonte spoke of it, when you don't have that holistic mindset when you're caring for a person. So that's I think what came to my mind. If you have a healthcare system that has a holistic philosophy or mindset, you might have an ease of suffering. Two other things: judgment and non-acceptance. I think that when our healthcare system judges us and doesn't accept us for who we are, our background, or what we bring to the table, right? Our patients need to be sitting at the healthcare decision table too. But when that doesn't happen and when there's judgment, suffering increases. I can just imagine. I have some family members who are recovering addicts, and the stories that they tell me about their treatment and their journey, right, through recovery, I'm just appalled at some of the situations. Again, that goes with practitioners needing to work on themselves, reflect on themselves, love themselves. And I love the word love. We need a broad definition of love, because I think I love everybody. I hope I love everybody. And I'm not going to be afraid to show that love for patients, for my colleagues, by the care I provide them. So in a nutshell, to summarize, I think if we have a healthcare system that is judging and not accepting of various cultures, ethnic and non-ethnic, suffering increases.
Exactly.
And let me throw this out there too, that when we're judging other people, when we're judging communities or populations, we are actually judging ourselves as better than. So judging is better than less than. So I always try to remember that and try to work on judgment, because it's human nature. It's human nature, and it's hard, and we'll automatically judge. So the thing is just to love and accept yourself, reflect on it, and the next time try to have better thoughts.
Exactly. And I also wanted to add, I mean, those were great points that you both brought up, but I also wanted to add, suffering to me is when we lose that caring response in our patient care, when we lose, that quality of patient care, when the quality is overshadowed by the quantity of patients you see per day, or the politics associated with health insurance and all of that, and just the love that you should have for your patient, and that caring response that should be there, is overshadowed by other things such as greed, or being too busy and not paying enough attention to your patients based on the number of patients you have. Or that's something that I've seen that happens a lot in practice, where patients are neglected for whatever reason, due to maybe there's too many patients to see per day, or there's not enough staff to cover. And that goes along with kind of other issues such as malpractice and things like that, that are kind of, we don't want to get into that, it's on a different note, but just seeing how, there is that lack of empathy that may exist, where you don't see your patient as a patient anymore, and that person just becomes a number, like you mentioned, or, the 3 o'clock appointment, rather than, the humanizing of the patient and that response.
Yeah, I was thinking about this issue of acceptance and non-judgment, right? Which just to show how complicated that is in practice, we might think of two populations that face a lot of judgment, and not populations is the wrong word. To kind of face, so a patient who is obese or overweight, or a patient who smokes. And Lauren Berlant has a really great piece about like the ways in which doctors do a particular kind of violence when they just say to a patient who smokes, like, stop smoking, right? That it's worth asking questions about like what role smoking plays in terms of stress relief. This is not an endorsement for smoking, everybody watching, but to think about if we really are committed to thinking about the patient as a whole, then it involves like going past what we might say is like, well, these things are unhealthy, don't do them, right? Actually seeing how complicated even the word like healthy is. When my mother was alive, she was overweight or obese her whole life, and faced that kind of judgment from everyone in the street. Like, so when we'd go to buy groceries, the checkout clerk would always say, did you see they have that in diet version or like low cal version? When she'd go to her doctors, that would always be the subject of conversation when actually, you know, she had a host of other medical conditions unrelated to her weight, and she was like, you know, didn't face the kinds of health complications that we so often stereotypically associate with obesity, right? And so like that's actually, so the point about non-judgment and acceptance becomes like, that's really easy to say and also really difficult for some doctors and nurses who come in with like these ideas, like I am trying to make my patients healthier, and to see how their own kind of prejudices or stereotypes, or how you might have to expand your definition of what healthy is if we are really taking like a biosocial approach to treating the patient as a complicated human being in a complicated world.
Yes. So there's a really excellent book called Against Health. It's written by a group of physicians. It's a compilation of essays. So it's not really against health, but against the moralizing tone that being healthy comes with, and that we conflate health with being moral and being unhealthy as being immoral. And one way that I've worked with my first year medical students, we assign a short clip from, or a short excerpt from Hunger by Roxane Gay, where she talks about being overweight her whole life, and that this was a response to the fact that when she was 12 years old, she was sexually assaulted, she says gang raped by a group of boys, and that she gained weight to feel bigger and stronger in the world, to also feel unattractive so that men would not come after her, and that she would take up more space and can hold her ground, right? And that her overeating, as she describes it, was a trauma response of unresolved trauma, and also a form of self-protection. The students read that and they're like, I never thought about obesity being a result of trauma or intentional in some way. And so undoing these moral tropes that we have around slothfulness, or you have no self-control or whatever, and really getting much deeper into why a patient is unhealthy in the eyes of the medical community, so that they can see their patient as a person. I would just say, and I would love to move on to the question in the chat too. So, but I would just say, like, a practical thing of developing emotional intelligence would be asking yourself, am I seeing this person that I'm supposed to be being emotionally intelligent with as a whole person? And I think that the emotional intelligence will naturally flow from that. I think when we default to seeing this person in front of me as someone who's just as complicated as me and just as vulnerable as me, then the right words come with that. That could take some practice, but it also just means taking a minute to pause. It's really hard. Like, sometimes I'm in a meeting and someone's being like a real jerk, and that's hard for me to humanize them because I want to just like dig my heels in and defend myself. But if I could take a deep breath and go, okay, where are they coming from? What are the emotional intelligence can come from humanizing that person in front of me.
Yes, absolutely. Thinking about, yes, reading about different life experiences, taking the time to think about what what are the meaningful pressures on people's lives? Absolutely. So the question in the chat kind of returns to something we talked about earlier, but is a good way of returning to key themes and ideas and going a little bit more in depth as a way of wrapping up. And so a note to other attendees, if you have a question, now's your chance. So the question is, what is the role of emotional intelligence and ethics in recognizing and combating systemic oppression in the healthcare field? And are there actionable steps that students could do or keep in mind or strive for to push for the changes that need to be made? So we talked a little bit about the importance of anti-racist education. We talked about the conversations that's happening on Twitter today about women being ignored or by their doctors when they make claims about their health. So do we have anything else that we want? Yeah.
Sure. So I love this question. And what I try to remind my students and what we can remind healthcare students in every field is that their voice is powerful, right? So this is why we see nurses and doctors posting about getting vaccinated or wearing a mask, right? Because there is, at least some remains, I hope, some social power that exists for people who work in healthcare. So the emotional intelligence comes with, how do I use my voice in a way that speaks to systemic oppression or issues of power, knowing that a voice in the healthcare field could carry more weight than other people's. And so learning how to articulate that messaging, and then to maybe think about, how do I get this in a public forum in a way that is not alienating, but does draw on truth and facts and science in a responsible way, to speak to these issues, and really empowering my students to use that voice. So I think we need to do more training, and I have students who want to write an op-ed and put it out in the world, right? And then how do they even go about doing that? And so us as educators helping to channel those voices in important ways, I think, is a practical, actionable way of being mindful of your social media presence and using your voice for good.
Yeah, this is definitely a problem, systemic oppression and racism, if you will, in the healthcare field. It's not anything new. We have, just in the past 2 or 3 months, there's been articles and news coverage from a director of a hospital and a physician who have basically told their stories on how they have been affected by this as African Americans working in the hospital system. So we know that it's there, and we know that it happens. The training that you mentioned definitely is something that was recommended, and that the hospital requested for all the staff after this came out and this allegation was made. And it was, they did some research on it and found out that it had actually happened the way the doctor had said that it had happened. And again, these are healthcare providers who were in the field. So these are individuals who one of them was a director of a hospital. So there was definitely a high standing position there where he could voice his opinion in a way where people would listen. So I think sensitivity training and making sure that people are aware and understand and are mindful of how their behaviors can impact others is key. And it's, like I said, it's definitely something that has been getting more attention now, especially during the COVID situation. The second case with the physician was related to COVID and the treatment she received in one of her own hospitals that she was an attending doctor, which is really unbelievable. So yeah, it's definitely something that we have to work on, and it's a learned process for some, and it has to be addressed.
So really quick, the answer to the first question there, the role of emotional intelligence. That is complex because we're in America where we have so many different cultures, so many different upbringings, social class, private, public insurance. We're a complex country. So emotional intelligence, I think it just starts with you. So that's my big thing about that. And that's why I think it's so complex that we are this melting pot versus you can go to other countries who are just one primary nationality. Actionable steps, love those ideas that were shared. Research your professional organizations and join your professional organizations, because there's a lot of times where I want to have voice, I want to speak, but I've got my job, we're all busy. We have our personal things too, but I support my organization and I have a president. I look at what they stand for, and that's where I will send my support. And it just last about a couple weeks ago, one of our presidents, I can't remember if it was at Arizona or American Nurses Association, our president was speaking about why there is difficulty with nurses getting the COVID vaccine. So I thought to myself, way to go. Thanks for being our voice for nursing when we can't individually speak ourselves. So professional organizations, but do your research first, make sure they follow your philosophy. Journaling and reflecting. I cannot say that enough, because any difficult situation can turn into a positive if you have that lesson and that takeaway. Labeling feelings and emotions, and then self-care with mindfulness. Those are the things that I would recommend too.
Thank you. As a kind of final wrap up, in part because so much of the incredible wisdom you've shared with us has been about the importance of really learning about people's stories, about reflection, about how difficult it is, the ways in which we can cultivate the deep skill of putting ourselves in someone else's position involves like really learning about different people and experiences and stories. So as my final question for the event, I was wondering if you had a book or a podcast or a movie recommendation that you think is particularly powerful and related to this topic that you would like to share with our students watching.
Okay, I have 3 stories.
Okay.
So, How to Be an Anti-Racist by Ibram Kendi, obviously, that's been helpful for me to read to understand my participation in systemic racism and microaggressions and all of that. Against Health, Jonathan Metzel is one of the editors. I just mentioned it before because it can help us understand how we judge patients. And then the other one I have right here has been helpful for me. This is Dying of Whiteness by Jonathan Metzel. I love Jonathan Metzel. This has been helpful for understanding what is the real rationality behind some of our country for some of the white communities' political commitments that undermine their own health. And why would someone do that? And this has humanized those groups of people for me. So I really recommend Dying of Whiteness.
Thank you.
We've got recommendations.
Anyone else?
Okay, I have a lot of really good books. There's one by Dr. Harville Hendricks, Getting the Love You Want by Dr. Harville Hendricks. And I like this book because it's about emotional intelligence, and it could be used across any disciplines, and it's really that human connection. Another short 3-minute video, you can Google Brene Brown empathy. Brene Brown empathy.
So good.
It's a short 3-minute video, and she gives you 4 components to develop empathy. It's developed by Therese Wiseman, a nursing scholar, but there are 4 components to empathy. And it is the cutest video, a little bit of humor. I watch it all the time with my students, but this is the type of seed that can be planted in your head. You go to this video often after an experience. And so those are a couple resources.
Excellent. I have put them in the chat for people, including a couple others. Medical Apartheid by Harriet Washington is a really excellent book about how we've used Black bodies as, and I use that term deliberately, as medical experimentation. So we often reference the Tuskegee experiment, but the danger of always referencing the Tuskegee experiment is that it erases so much other violence that has happened for so long, including, let's say, the entire field of gynecology was built on the bodies of imprisoned women, of Black women, and of enslaved persons. So, oh, thank you for correcting. Dr. Piemonte has written a beautiful book called Afflicted, which is about how vulnerability can help in medical education and a focus on suffering. Brilliant Imperfection by Eli Clare is a book that talks about that. Eli Clare is, it's part ethnography, part memoir, part poetry, really thinking about how we can learn from bodies that have disabilities and from trans narratives to really trouble the notion of cure. And it's a really beautiful book. And so I would also highly recommend the Against Health book. It's the essay that I referenced about smoking by Lauren Berlant is in that book. And so that there are some recommendations for some reading, you know, nobody does that in college. So highly recommend that you just read as much as possible, so that when you go to write that narrative to get into nursing school or med school, that you can show that you've spent time thinking about how important emotional intelligence and ethics is, not just in a superficial way, but really, truly, substantively, to bring care and meaning to your patients' lives. So does anybody have anything they want to say quickly? And I've asked so much of you over 2 hours, but if there's something that you wanted to say as the close that I didn't ask.
I just want to thank you for inviting me to participate in this. I think it's amazing that ASU is having these kinds of conversations that are so, so important. So just grateful to be a part of this today.
Thank you all so much for sharing your wisdom. It's been, I was nervous about 2 hours, but it flew by, and I hope it's been helpful for our students and for all of you who are watching later. Our participants are easy to find and would be happy to answer your questions, as would I. Thank you so much for your interest in this topic, and I wish you all rest and energy as we move forward in 2021.
You too. Thank you.
Everyone.
Thank you.